So hello everyone, welcome to my channel. I am Dr. Saurabh Dixit. So greetings for the day, and today again I'm going to discuss a very small crisp topic, and that topic is very important for everyone. I'm going to discuss about shock, and I will discuss it in a nutshell so that within 15, 20, 25 minutes we get to learn the topic, and not only learn, understand it, so that we are able to answer any question that is arise from it. Or as a doctor, when you are treating the patients, you should be confident about that. So welcome to my channel, and let us start with this topic of shock. Now, what do we mean by shock? The first thing is, what is shock? So shock is nothing, it's a state of hypoperfusion. So when you talk about state of hypoperfusion of the tissues, what do you mean by the state of hypoperfusion? Now, the state of hypoperfusion can arise because of low volume. The state of hypoperfusion can arise because the volume is there, but it is not getting circulated from the heart. That is what is cardiogenic shock. It could be a neurogenic in origin. What do you mean by neurogenic in origin? It is central sympathetic stimulation is lost. So there is pooling of the blood in the peripheries, and blood is not going to the adequate right place. Or it could be under the influence of an exogenous toxin, that is in case of septicemia or septic shock. So this is what is a brief thing that we need to understand. So since this is, I want to concise the topic, so I will discuss it in that form only. So let us have an overview of shock. Now when you talk about overview of shock, I'm going to compare various shocks on their different aspects and parameters. So what are the varieties of shock we have? So we have hypovolemic shock. What do you mean by hypovolemic shock? The blood volume is less. The second is, we have cardiogenic shock. So when you talk about cardiogenic shock, what do you mean by cardiogenic shock? It is a state of pump failure. The heart is not pumping the blood properly. The third is, we have neurogenic shock. So what is neurogenic shock, students? Neurogenic shock is a state when there is loss of central sympathetic tone. And the last is, we have septic shock. So these are the four varieties of shock that we are going to compare. So the first thing that I will discuss with you is the concept of heart rate. So when you talk about heart rate, students, what is so important about heart rate? Now, whenever there is shock, the blood is not coming out of the heart, or in case the blood volume is less. So the heart is making, or blood is making more cycles. So definitely the heart rate is increased in all the types of shock except one. So hypovolemic shock, it is going to increase. Cardiogenic shock, it is going to increase. Septic shock, it is under the effect of toxemia, toxins, that there is SIRS, systemic inflammatory response syndrome. So there is tachycardia. What happens in neurogenic shock? There is central sympathetic shutdown or loss of sympathetic tone. So this is the only place where you get to see bradycardia. So this is what is very important. So you get to see bradycardia. The next important thing is, let us talk about respiratory rate. So when we discuss about the respiratory rate, what are the things that we need to understand? So respiratory rate also will increase. So there is tachypnea in cardiogenic shock as well as in hypovolemic shock. This is also the scene which is seen in the septic shock because of the intense inflammatory cascade that is going on. The next very important thing is what happens in neurogenic shock. Students, in neurogenic shock, there is central loss of tone, and that is why you get to see what? Bradypnea. So decrease respiratory rate. So these are two important things that we have seen. The third very important thing is the peripheries or extremities, because you generally assess the patient by touching the hand, examining the pulse, and also looking for the temperature, local temperature. So when we talk about the peripheries, so what happens, students, it is the rule of body that whenever there is any form of shock, the major chunk or major pool of the blood will be diverted to the essential organs. And that is why the lungs, the kidneys, the brain, the heart, they are the one who are actually wanting the, you can say, blood to sustain themselves. That is why blood is diverted from the periphery. So there is increase in peripheral resistance, and that is why there is peripheral resistance is increased, so less blood is there, and that is why extremities tend to be cool. So why the extremities are cool? Because of the concept of vasoconstriction. So vasoconstriction is there in both cardiogenic shock as well as the cardiogenic shock and hypovolemic shock. The next is what happens in case of neurogenic shock. In neurogenic shock, everything that is developing is just because of one factor, that there is central loss of what? Sympathetic tone, and that is what is very important aspect. So there is peripheral pooling of the blood. So peripheral resistance is decreased in this case rather than getting it increased. So there is pooling of the blood, and when blood is pooled there, the extremities are warm. So basically here you get to see vasodilatation. Vasodilatation is the factor which is very important here. And what about in septic shock? So students, initially it is due to the effect of toxins, that is bacteria, that the extremities are what, students? Warm. But as the shock overtakes the body and systemic, you can say metabolic slowing is there, so later it will also behave like a patient of other hypovolemic or cardiogenic shock. So extremities become what, students? Cool, and this is because of vasoconstriction. So in the early phase, the extremities are warm, not because of vasodilatation, it is because of the effect of the toxin. So toxins are very important, you can say, character in this. Next is, what else do you see? Apart from that, we have a tendency to look at the jugular venous pressure. So what is the status of CVP? Now try to understand, whenever the volume in the body is less, the CVP is going to fall down. Whenever there is pooling of the blood in the peripheries, then also, whenever there is metabolic, you can say, slowing because of toxemia, then also it is going to be low. So remember, it is low for hypovolemic, low for neurogenic, low for even septic shock. But in case of cardiogenic shock, the heart is not pumping because of the state of pump failure, and thus the blood which is trying to enter has to face more resistance. So if this is the heart which is not allowing the blood to enter, and this is the blood, so blood will have to face a higher resistance to enter, and that is the time when the rebound, you can say, escalation of JVP happens. So yes, it is the CVP or JVP is high in cardiogenic shock. This is what is very important fact. Then there is something which is known as Embose. Embose. What is Embose, students? This is again very simple. Mixed venous O2 saturation. So what is the concept of mixed venous O2 saturation? Now let me tell you in a layman's language what is Embose. Embose is nothing but it is a quotient which is reflecting the level of oxygen utilization by the body. Let me make it very simple. In a layman's language, you give the, let us behave like, you can say, let us talk about investments and let us talk about commercials. So it's a business. The heart has a business of giving the blood out, along with that oxygen loaded blood out of the heart. Now blood is again returning back to this heart via vena cava, it is going via aorta. So heart says you are taking 97% of oxygen in you. When the vena cava is coming, the heart is asking how much oxygen are you getting back. So do you know roughly the saturation of the, or you can say, blood at the level of right atrium is reflecting how much blood has been utilized. So if 97% has been sent to the body and 70 is what is the saturation in the vena cava at the level of right atrium, so you know 27% roughly around has been utilized by the body, and this is what is how we check Embose. So what is mixed venous oxygen saturation? It is the level of oxygen saturation at the level of right atrium. We say it right atrium, but remember you cannot measure it. We measure it at the level of pulmonary artery, because there is no factor of oxygenation when you move the blood from right atrium to right ventricle and then to the pulmonary artery. So via Swan-Ganz catheter that is put in the pulmonary artery, you can check this. So normally what happens, a normal MVOS. What is a normal MVOS? It is roughly around 65 to 70%. So I would like to explain it again in this chart only. Let us see. This is heart. So imagine this is heart. Heart is taking the blood out and it is going to the body, and these are the organs of the body. Imagine these are the organs of the body, and they are extracting the oxygen and returning it back via vena cava. So this is aorta, which is having suppose 97%, and this is vena cava. So when vena cava takes in the blood, and we expect here the saturation of 65 to 70%, this is how we decide the normal MVOS. Now, why is this important in case of hypovolemic shock or any shock? Answer is, if the perfusion, what is shock? Shock is a state of hypoperfusion. So if the shock is still present, the perfusion kinetics will never come to the normal. There could be a possibility that urine output has been compensated, but remember, the tissues will always be thirsty because there is a state of hypoperfusion and they will be extracting more than the usual. So try to understand, in case of hypovolemic shock, when the blood volume is less, the level of extraction from the remnant volume will be more. Example is like, if 6 liters of blood is giving 100 molecules of oxygen, now you have only 3 liters of blood. So 3 liters of blood will be giving 100 molecules of oxygen. So there will be more extraction from a lesser volume. This is what is very important. So in hypovolemic shock, the blood which is returning back to the heart will have a more extraction, and therefore the oxygen saturation will be lesser than the usual. So low MVOS indicates less than 50% oxygen saturation, at the level of, you can say, right atrium, indicates ongoing hypovolemic shock. So in hypovolemic shock, what do you get to see? You get to see low MVOS. Same is the case with cardiogenic shock. Now, why cardiogenic shock? The blood is there, the volume is there, but heart is not pumping out that very same volume out. So when heart is not pumping out that same volume, a lesser volume will be secreted out of the will be ejected out of the heart. So remember, if 4 liters of blood is given to the body will say, give me my 100 molecules. Earlier you were giving it from 6 liters. So 6 liters was supplying 100 molecules, now 4 liters are supplying. So there is higher extraction of oxygen from that lesser amount of blood. So there will be overutilization, and the blood which is returning back will say, I carry lesser than the usual oxygen. And again, low MVOS in this case will be indicative of what, students? Ongoing hypovolemic shock or cardiogenic shock. Now let us talk about the neurogenic shock. When we talk about neurogenic shock, now students, in neurogenic shock, the problem is the distribution pattern is different. Like you see, a distributive shock. The blood is not going to the organs. It is getting pooled in the peripheries. So when periphery has a lot of blood, peripheries will not extract oxygen. Oxygen extraction basically is by the metabolically hyperactive organs or active organs. When blood is not going to those organs, the oxygen will not be extracted, and thus the unused oxygen, or you can say blood which was underutilized, will be returned back. Body will say, I have given the blood, but unfortunately the tissues didn't get the blood. Why? Because it was pooled in the periphery. So when the blood is returned back to the heart, it is basically having a high oxygen. Remember, low oxygen levels indicates more, you can say, extraction. High oxygen level indicates lesser than the usual extraction, and this is why both of them are suspicious. So level more than 70% of oxygen saturation at the level of right atrium basically indicates a state of ongoing hypovolemic shock. Next is ongoing neurogenic shock. Next is, let us talk about sepsis. In case of sepsis, blood is going to the organs, but because of the toxins, because of the bacteria, the oxygen extraction or the metabolic rate of the tissues, or metabolic, you can say there is a metabolic slowing of the tissues. When metabolism is slowed down, why will you need oxygen? So in case of toxemia or septic shock, the extraction from the blood to the tissues is not there, and that is why blood takes the oxygen, says, hey tissue, you want this blood? no, bacteria doesn't need it. Bacteria doesn't need it. And thus the blood is returned unused. So in case of septic shock, remember again the underutilized blood is sent, and therefore you get to see, yes, a higher than the normal, you can say, Embose. So Embose is again a very important you can say characteristic feature, because we say that urine output is very important, but try to understand, students, urine output is compensatory clinical mechanism. And remember, over the time, class 1 type of hypovolemic shocks or the shock correction clinical is first, and then the tissue level shock correction is there. So if you just see urine output as an adequate parameter and stop the process of resuscitation without knowing that the cells are still starving, the patient can decompensate. So it's very important for you to understand this very basic concept. The next is, in this overview only, let us discuss about the management. So when we are talking about the management of hypovolemic shock, cardiogenic shock, neurogenic shock and septic shock. In hypovolemic shock, you require fluids. So fluids are very important. And remember, when we talk about the fluids, the first line fluid that you use is crystalloid, and along with crystalloids plus minus, these patients are going to require blood transfusion. So I shall cover up this transfusion protocols etc. in a different video. But remember, if you give too much of fluid in terms of crystalloid only, you will be diluting the blood, and thus dilutional coagulopathy is there. So beyond a limit, yes, blood needs to be replaced by blood only. When you talk about cardiogenic shock, already the blood volume is there. The heart is not able to pump. There is increased preload, and if you add more fluid, there will be metabolic chaos created. So heart is already overburdened, so try to reduce the fluid levels. So fluid restriction, it's very important for you to identify what type of shock you are dealing with, because the management is totally different for every type. So along with this, we need something to stimulate, and therefore inotropes for this cardiogenic shock. Then what about neurogenic shock? Neurogenic shock, you need fluid. Why? Because majority of the fluid is getting pooled. So you need fluid also, and along with that you need inotropes also. So both of them you require. Now when we talk about septic shock, how to manage them? This is again very simple and straightforward. For septic shock, you require fluids, yes. Along with that, you require antibiotics. So broad spectrum antibiotics are also there. So fluid is there, antibiotics is there, and plus minus inotropes are also there. So this is what is a simple basic concept overview of shock. Now the next 10-15 minutes I am going to devote it to the basic understanding of the different type of shocks. Neurogenic shock I have just completed in front of you, so I don't need to, you can say, teach it again. So basically I am going to teach you the other forms of shock. So the next is, let us talk about cardiogenic shock. So when you talk about cardiogenic shock, what is the concept of cardiogenic shock? How it is important for you? Simple. Understand, cardiogenic shock is nothing but a state of pump failure. The heart is not ready to pump the blood. And now what could be the reasons for these pump failure, students? There are three important directions where you can think of. Sir, there could be some functional problem with the heart. So functional type of cardiogenic shock. So functional cardiogenic shock. Sir, there could be some problem with the flow, obstruction to the flow. So obstructive cardiogenic shock. So obstructive cardiogenic shock can be there. Yeah. And sir, there could be possibility that flow is there, functional capacity is there, but someone is giving an external pressure that you will not work, and that is what is compressive cardiogenic shock. So there are three varieties. So compressive cardiogenic shock, obstructive cardiogenic shock, and functional variety of cardiogenic shock. So let us try to understand them. In a layman's language, it might look that it's a very difficult thing to understand, but it's very easy. So functional variety, it is associated with functional compromise, functional compromise of heart. So example for this is ischemic heart disease. So if a patient is having ischemic heart disease, the heart is not pumping the blood properly. So that's the same thing. When you talk about obstructive cardiogenic shock, what is that? There is obstruction to the flow. So this is associated with obstruction to flow of blood. So how is this possible? The classical example for this is aortic stenosis, tricuspid stenosis, pulmonary stenosis, mitral stenosis, and there is one more thing. If you go to my lecture of tension pneumothorax, in the late part, when there is too much of lateral traction, you can visit my video and you can read tension pneumothorax. In the later part, there is kinking of the vena cava because of the partial rotation or twist of the heart, and thus the death occurs because of the obstruction to inflow. So tension pneumothorax, the cause of mortality. So in case of tension pneumothorax, the cause of mortality is this. This is what is very important, very important. Now when you talk about the compressive cardiogenic shock, how is this possible? So this is associated with external compression. Now when you talk about external compression, buddy, what is this external compression? So imagine I am heart. So here there is one lung, here there is one lung. Out of them, one starts to grow bigger. Why? Because of pneumothorax. So when this lung is becoming bigger, it will compress the heart. Or in case of positive pressure ventilation, PPV, that is a forced positive pressure ventilation. Third is in case of cardiac tamponade. So in all these cases, the heart is getting compressed from outside, and that is why it is not able to pump the blood. So the examples or the association, it is tension pneumothorax. Do you know tension pneumothorax? The definition is any pneumothorax associated with what? Compressive cardiogenic shock. The second is, I have told you, that is cardiac tamponade. And the third is, it is nothing but positive pressure ventilation. Management I have already discussed briefly with you. Next is, students, just like we discuss the cardiogenic shock, summary of septic shock also, because we should be touching all the shock so that you understand. So septic shock. Now when you talk about septic shock, there are few important things that you need to understand. The first thing is, what is the criteria for SIRS? And once you understand SIRS, then only you will understand what is sepsis and septic shock hence. So SIRS stands for Systemic Inflammatory Response Syndrome. I hope you are guessing it right. Now what are the parameters? You can comment in the comment section below. What are the parameters for SIRS? Heart rate more than 90 per minute. Remember this year there was a question where they have asked in INICET this year, they have asked that systolic BP less than 90. No, systolic BP is not a part of this. So heart rate, then respiratory rate more than 20 per minute, or if respiratory rate is more, then PA CO2 levels should be less than 32 mmHg because of the hyperventilation. The third is temperature of the body on the either sides more than 38 degrees Celsius or less than 36 degrees Celsius. Both are important. So heart rate, respiratory rate, temperature, and one more thing is WBC count. WBC count more than 12,000 or less than 4,000 per mm cube. So they are very important, and out of those 4 parameters, if 2 or more are positive, so out of them, if 2 or more are positive, this is known as SIRS positive. It's a very simple thing. Now students, when we have SIRS as positive, so if SIRS is positive, along with that, if you send a culture and the culture shows growth, so if infection is there, so SIRS plus infection, this is equal to sepsis. This is again very important. And then sepsis plus hypotension, this is actually known as what, students? This is known as septic shock. This is again very important thing that you need to understand. Again, one more thing that you need to understand is sepsis plus organ dysfunction. So sepsis plus MODS, you can call it as sepsis syndrome. So there are a lot more other things also which I discuss it in my routine class. You can go to my app and just check out my courses. So we have a lot of things for you. We are bringing up with Ultra HD recorded videos for you, and they will be very helpful for you. So since this is a summary class, this is a summary of the topic, I'm not going to that depth, but you should know that procalcitonin, small cluster determinant CD14 is again a very important, pre-sepsin is again a very important marker. So procal is a very, very, very important strong marker for this. And then you get a question on QSOFA, which is a prognostic score. And now I shall be going, I have already discussed the management of septic shock during the overview. So now I will be telling you or discussing with you the concept of hypovolemic shock. So again students, hypovolemic shock, as a question you get a lot of things in amongst parameters and this and that. So let us see hypovolemic shock. The first thing is, let us talk about the grades. So when you talk about the grade of the shock, how many grades are there? So grade 1, grade 2, grade 3 and grade 4. It's very easy to say 1, 2, 3, 4, but the next question is, how are you grading? What are the threshold values on which or on based on which you are deciding? So the most important thing is on the basis of percentage blood loss. So when we talk about the percentage blood loss, to make it easy and memorizable and recallable, so we have modified it to what? A score of a tennis match. So let us say first point is at 15, then 30, then 40, you win. So less than 15% grade 1, 15 to 30% is grade 2, more than 30 up to 40 it's grade 3, and more than 40 is obviously it's a grade 4. Do you know? Because of this classification is also known as tennis classification. Then on the basis of ml loss. So ml blood loss, when you talk about ml blood loss, what do you mean by this ml blood loss? How much is in ml blood is lost? So you can do the grading. Less than 750 ml, then 750 to 1500 ml, then more than 1500 ml to 2000 ml, and more than 2000 ml is grade 4. Now some students might be taking out that 6 liters and then 40% and this and that. Students in surgery, we make the things easy and memorizable. So if there's a variation of 15, 20, 100 ml, we just take and round off of that. So don't worry, don't start calculating and saying, okay sir, you have written above 40% here, it is not corroborating, 40% should be 2400. Students in surgery, we don't have anything like Haka-Faka syndromes, Laka-Faka syndromes. We keep the values as simple as that. Because during surgery, the adrenaline factor never allows you to recall the complex things. So we make it easy and memorizable so that you don't have to mug up those things. It is once it is fitted inside you, like rule of 9. In burns, you never forget. Even if you try to erase it from your brain, every day you say, no, I don't want to revise rule of 9. Once you have read, it's there in your brain, and that is how the things are. Same is the case with formulas for the fluid. This is very simple, 150, 20, 4, 2, 1. This is how we practice surgery. So we need to feel like a surgeon, think like a surgeon, and then only you will enjoy the subject. The next is, let us talk about the heart rate per minute. Remember, grade 1 is always a compensated version of shock. So you will always see the parameters as compensated. So less than 100, more than 100, more than 120, and more than 140. So less than 100, more than 100, more than 120, more than 140. Next is, when you talk about systolic BP, so it is normal for grade 1, and do you know it is also normal for grade 2, and that is why we don't rely a lot on systolic BP. So if you want a comparison, strong comparison, go for MAP, mean arterial pressure. So mean arterial pressure is normal for grade 1, but for grade 2 onwards it starts to fall, and this is where the diligence comes. So this is what is important. After that, what are the other factors that you see? You see respiratory rate. When you talk about respiratory rate, students, this is per minute. So 12 to 20 is grade 1, more than 20 up to 30, more than 30 up to 40. Now the students who are thinking that grade 4 should be more than 40, let me tell you, persistently elevated respiratory rate beyond 35 is taken as grade 3 or grade 4. So like suppose there is a respiratory rate of 37. So 37 can fall into 3 also and 4. So now you need to check other parameters. So imagine if there's a patient who has a respiratory rate of 37 and heart rate of 126. So it falls in grade 3. Same patient with a heart rate of 146, it falls into grade 4. So you need to diligently decide based on the other parameters. So next is, so this is respiratory rate. Then what else? Students, urine output is again very important. So urine output, and taking an average for 60 kg individual with an average rate of 0.5 ml per kg per hour. So more than 30 ml per hour, more than 30 ml per hour is justified. So if it is 80 kg, so it should be 40 ml per hour. This is how the things are. In same proportion, you have to grade it. So 20 to 30 ml grade 2, 5 to 15 ml grade 3, and nil, that is grade 4. Then we often take the mental status of the patient. So if you talk to these patients, they are oriented. Grade 1 patients are oriented, they will tell you everything. Grade 2, they are anxious. Grade 3, they are restless. And what about grade 4? They are confused, they are lethargic, lot of things are there, disoriented basically. Now when it comes to treatment, students, you need to give the fluids. Now when you talk about fluids, the first thing is from grade 1 to grade 4, all of them will require what, students? All of them will require crystalloids. So this is what is very important. So crystalloid is important, and I've already taken a chapter in depth also, and in a concise version on this, my YouTube threads, you can go through that and go through the chapter of fluids also. That's very important. So crystalloid, 0.9% NaCl is what is the choice in case of hypovolemic shock. But remember, for grade 3 and grade 4, you require blood also. So blood is required for grade 3 and grade 4. Now this is what is very important. So with this, we come to the end of this small, you can say concise description of the shock. But there is one more thing. What are the end parameters of shock? Now this is where the diligence comes. So end parameters of shock, when you start with the resuscitation, you need to you can say assess the patient, whether the patient has recovered or not, and stop the process of resuscitation. So what are the parameters for that? So clinical, when you talk about clinical, the most important clinical parameter is your urine output. And when you talk about urine output, there are a lot of parameters. I usually teach this topic for 2.5 hours, but I've just tried to get a summary video for you so that you can watch, enjoy, revise quickly. So taking for an adult, it is somewhere around, more than it should be 0.5 ml per kg, more than 0.5 ml per kg per hour. For kids, it should be 1 to 1.5 ml per kg per hour. For infants, yeah, they have to maintain it at 2 ml per kg per hour. This is what is. Apart from that, there are some perfusion based end parameters also. So what are the perfusion endpoints or end parameters? You can say this is NIRS. What do you mean by NIRS? This is near infrared spectroscopy. So spectroscopy will allow the perfusion to be gauged. Apart from that, there are some arterial blood parameters. So when you talk about arterial, you can say Embose. Embose is considered to be the best parameter. Remember, if you get a question where Embose is also given and the urine output is given, then see what they are asking. If they say guide for resuscitation, initial guide for resuscitation, the most important clinical parameter, urine output. If they ask best parameter to decide the recovery of patient from shock, Embose, if it is there, it is better than urine output. And then lactate levels. Remember, you can use CVP. This is unreliable. Why? You cannot rely on CVP. So I hope you enjoyed this small crisp lecture on the shock. I hope you will learn along with me. So let's learn and share it with your near and dear ones. If you're still not subscribed to my channel, do subscribe so that you get notifications, and do not forget to press the bell icon. Do comment in the comment section whether you liked or not, or yes, if you want any topic to be revised, or if you want me to make a video on any topic, I will always be overwhelmed for that. So till then, bye bye. Keep waiting for the next video.